So I've been asked to speak to you about the management of subclinical cleft in adults. Just so that you can understand how cleft lip and palate services are provided in the United Kingdom. For the last 30 years, they've been centralised into 12 services. So I'm based over here in the Purple Service in South Wales, and the hospital there is in Swansea, and we're currently here in the light green in CleftNet East, and the hospital there is Addenbrooke's. So there's 12 services. There are actually 16 stars on there, so some services have 2 hospitals. So over the next 15 minutes, I'm going to talk to you first about the anatomy of the palate and how that relates to speech. I'm then going to talk about the diversity of different types of cleft palate, which Tom actually touched upon in his talk very well. And then finally, I'm going to get to the thing that I've been asked to speak about. So that's assessing and managing the palate in adults who might have a subclinical cleft in the stickler population. So I'm biased, but I think the anatomy of the human palate is just absolutely stunning. It really is a beautiful piece of engineering. And so this picture from the side view shows the palate, the roof of the mouth. And at the front here, we've got the bony palate, which only functions to separate the mouth and the nose. It doesn't move. But then at the back, we've got this exquisite soft palate, which has this muscular bundle in it, and it's able to move up and down. And that's important because at rest, it flops down and air can freely flow through the throat into the nose for breathing. But then when it rises up and closes up to the back of the throat here, that creates a barrier between the nose and the mouth. And this is really important for the formation of sounds. And to appreciate how amazingly this works, which for a significant proportion of people born with sticklers, it will work beautifully because they'll have a structurally, anatomically intact palate. This is a video of someone who is beatboxing inside an MRI scan. So it's a fantastic, you may have seen this on YouTube, but just look at how active and mobile this soft palate is in this beatboxer. So here we go.
Hello, my name is Timo Schnepp, and I'm going to perform a beatbox freestyle inside a real-time MRI.
Tongue here, soft palate here.
Here we go.
So you can see it really lifts up and makes this seal at the back of the back of the throat. So some people born with Stickler Syndrome will have a structurally not intact palate, and this may be in the form of a cleft palate. So cleft meaning a gap, and there are various types of cleft palate. On the left here, you can see that these are intraoperative photos because it's quite difficult to get good photos of cleft palates without this surgical instrument, which helps to open the mouth in a very safe way. I know it looks pretty barbaric, but it doesn't cause any harm, this instrument. But this is a incomplete cleft on one side. It's relatively narrow, and it mainly involves the soft palate at the back and just a little bit of the hard palate. Whereas this is more of a complete cleft on the right. It involves all of the hard palate as well as the soft palate, and you can see the gap is much wider. And for patients born with a cleft palate, usually this is picked up in the first days of life here in the United Kingdom with the newborn test, and they'll be referred through to one of the 12 cleft services. And then at approximately 9 months of age, I in Wales and the other 30 cleft surgeons in the United Kingdom will plan to do a surgical operation to reconstruct the palate, and this will consist of a design on the cleft palate, and then at the end, this is what we would hope to achieve: a closure of the palate along the midline, and hopefully those muscles can now work to elevate the palate to the back of the throat. But for some people born with Stickler syndrome, they may not have an obvious cleft of the palate, but still the structure of the palate may not be completely how we would expect. And they may have a form of submucous cleft palate. And this means that the tissues have fused and formed, but the tissues aren't completely as functioning as normal. Now, one sign of this, as Tom mentioned, is a bifid uvula. It doesn't project very well here, but these are two forceps trying to pull the uvula back, and that there are two bits of the bifid the uvula. So rather than a single bit, there's two. Now, importantly to say that a proportion of the population are born with a bifid uvula and a completely normally functioning palate. But it is a sign for us to look a little bit closer and think, are there something going on underneath the tissues of the palate that may not be working as well as a normal palate would? So this is quite a subtle submucous cleft palate. This is much more obvious. You can see that there's a really obvious bifid uvula here. And whilst the tissues have fused in the midline, you can see that, in fact, the muscles are on either side. And whilst the mucosa, the wet tissue of the mouth, has fused, actually the muscles haven't fused. So this type of submucous cleft palate, the palate won't have much of a chance to rise properly up to the back of the throat, because that sling of muscles isn't intact. So there's a gradient of submucous cleft palate. What makes it even more complicated is that sometimes there's no sign of a submucous cleft palate at all. It looks like the palate's completely normal to look at, but still it doesn't function as we normally would expect. So this is relevant for the stickler population because maybe as a baby they haven't had a problem identified with the palate, but maybe when people grow older, there are problems with speech, which is complicated because people sometimes have hearing problems. But if they go and get assessed by a speech and language therapist, the speech and language therapist may say, okay, I think there's a structural problem with the palate here. That's what I'm hearing. And so even with a normal looking palate, it still sometimes doesn't lift properly to the back of the throat, and so air can escape through into the nose during speech, and that's what the speech and language therapist might hear in the community if a person gets referred through to them. So in the UK here, every one of those 12 cleft centres has a specific clinic to assess and manage people who have a speech problem where it sounds as if air is going into the nose. And at these clinics, there's a full team, a multidisciplinary team of surgeons like me, and speech and language therapists and psychologists. And there's a set routine to assess patients to see how their palate is functioning, what's going on. And this consists of, firstly, a speech assessment with the speech and language therapist. So they'll go through a standardized set of words to try and find out what's happening. And then there'll be a clinical examination with the surgeon who will look carefully in the mouth and see how the palate's lifting up. And finally, some imaging, and that consists of an X-ray from the side to show how the palate is lifting, and also a nasendoscopy, which is a small camera which goes down the nose. So this is the X-ray from the side. Obviously, there's no patient here. There's a doll instead, just to show you where the patient would sit. But this is the machine that fires the X-ray, and then this is the screen that will capture the X-ray. And it's a very straightforward thing. The patient would sit in the blue chair, and the speech and language therapist would be in front of them, and the speech and language therapist would say some sentences, and the patient would be asked to repeat those sentences. And all the time, this X-ray machine is seeing what's going on. And so we get moving images. This image doesn't move, but this is the sort of image that we see. So here's the lower jaw, here's the upper jaw with the teeth in there. This white cavity up here is the nose. The mouth's closed here, but this would be a white cavity, which is the mouth. And then this dark sort of sausage like structure here is the palate, which is at rest here, because you can see this white air structure at the back. But we'd hope when the X-ray started going that if their palate was functioning normally, then this black structure would meet and rise to meet the back of the throat here. And if there was still a white stream of air that was visible, that would suggest that the palate's not lifting up properly. It's not always easy to see on this X-ray, so sometimes we need to proceed to nasendoscopy, which is the small camera which goes down the nose. So this is less, the diameter is less than your finger. And so for children coming into this, we say, I bet when your parents aren't looking, you sort of pick your nose with your little finger, and that doesn't hurt. So this doesn't hurt either. It's not pleasant having I don't know whether anyone's had a camera. You wouldn't want to have a camera in your nose, but it doesn't hurt. It's just a little bit uncomfortable. So then, if we identify a problem with a palate in an adult with someone with Stickler syndrome, what can we do? Well, there are various options. First of all, we can do nothing, which is an important option. It's absolutely everyone's choice, and it's your choice to make. So that's important to know. Some speech problems can be amenable to speech therapy with the speech and language therapists. But if there's a structural problem with the palate coming up to meet the back of the throat, probably the speech and language therapists are going to be limited in what they can do because they can't change the structure. There are surgical operations that I can do, and I'll show you how some of those might look. And there are non-surgical operations. So there are appliances which can be put in the mouth, which can help lift the palate to the back of the throat. So what kind of operations can we do on a palate that doesn't have a cleft? Well, this is a procedure called a furlough procedure. And what it does, it's a very elegant procedure. It lengthens the palate, because you can imagine if we find that the palate is a bit short, it's just not long enough to meet the back. This very clever Z shape, when it's reorientated into this new shape, it means that it pushes the palate back, and it also at the same time makes the muscles work a little bit better. So that can be a good operation. Sometimes we need a little bit more length on the palate than just reorientating the palate itself. And this is called the buccinator flap operation. And this recruits tissue from the inside of the patient's cheeks and then turns it over into the palate itself. So it divides the hard palate here at the front and the soft palate. So it physically pushes the soft palate back. So it's got more chance of meeting the back. And sometimes it's not appropriate to operate on the palate itself, but we can look to the back of the throat. And if we bring the back of the throat forward a bit, then the palate has a better chance of meeting the back. So it sort of creates a speed bump here on the back of the throat for the palate to meet. And so we design some trouser legs on the back of the throat here, and lift those trouser legs up so that they cross over like you're crossing your legs, and it makes a speed bump for the palate to lift on. But then some people really don't want an operation, but want their speech to be better. Maybe some people can't have an operation because it's not safe for them to. And so there are appliances, a very simple one here on your right, a plug to go into the nose to stop air leaking out during speech, which can be very effective. Or this device which clicks into the teeth and physically pushes the palate up so that it can reach the back of the throat a little bit more easy. You can imagine it takes a little bit of getting used to having this in your mouth, and not everyone will tolerate that. So this is a picture of the Gower Peninsula where I've just moved to in Wales. So I'm fully embracing the Welsh life, and it's a real pleasure to come here today and speak to you, and I'm very thankful for it. Thank you.
Many thanks, Matt. I'm trying not to break the microphone this time. Anybody have any questions that they'd like to ask Matt? Just come in over.
Hi, it's Janice. So I was
Janice.
born in 71. Obviously I couldn't take milk because of the cleft, but I had something when I was probably about 6 or 7 called a laryngoplasty. I don't really know what that was, but I did follow the fact that I spoke very late as well, so I had speech therapy. Well, have you heard of a laryngoplasty? I mean, it's obviously an old procedure. So I had that in the sort of mid-70s.
Yes.
And also, I was born with Pierre-Robin syndrome. I don't know if that's anything to do with the jaw or the palate.
Thank you.
Yeah, well, lovely to meet you, and great to hear your story. I think you probably had a pharyngoplasty rather than a laryngoplasty, but the terms are so confusing, and I apologise on behalf of the cleft community for it. It doesn't make it easy. Yeah, I think you probably had a pharyngoplasty, which is moving the tissues at the back of your throat to make the hole smaller between the nose and the mouth, and it just is helping your palate to make that seal during speech. Did it help? Did it help your speech?
I think it did. A lot of people, my dentist will know I had a cleft done, but not many people would know my speech. So I think it did help my speech, and everyone said I'm not sure since, so
Yeah, I mean, you sound incredibly clear, and I can very easily understand everything that you're saying. So it sounds good. Excellent. I'm really pleased to hear that. In terms of Pierre-Robin sequence, yes. So Pierre-Robin sequence is a constellation. I'd classify it as a constellation of signs. It typically involves a small jaw, and when you were young, probably your mouth was at the your tongue was positioned quite far back, and you may have had breathing problems. In the cleft community, we go on high alert whenever a patient is born or identified to have Pierre-Robin sequence, because we recognise Stickler syndrome to be the most common syndrome associated with the Pierre-Robin sequence. It was interesting speaking to the team in Cambridge, because we obviously see it from a cleft perspective. So for everyone born with a Pierre-Robin sequence, we would go overdrive to try and rule out Sticklers. Whereas I think that speaking to the team here in Cambridge, their thought of cleft palate and the association with Pierre-Robin sequence was different, because they see it from the other side, and so they were saying, well, we see patients with Sticklers who have Pierre-Robin or don't have Pierre-Robin. So I'm not sure how strong that connection is with Pierre-Robin.
Makes sense, because I was diagnosed with Pierre-Robin first. I was diagnosed with Pierre-Robin first, and everyone thought that's what I had. I was diagnosed with Stickler at 16, so right. Yeah, it was almost that way round.
Yes, well, it's really interesting. Thank you for sharing.
Thank you, Janice. Sorry.
What's the purpose
can you wave your hand so that I can get it on mic? Thanks.
What's the purpose of the uvula? Is that the part that actually is closing the soft palate?
So I mean it's contentious, and it's much debated in cleft conferences. People will passionately argue on both sides. There is a muscle so there are 5 paired muscles in the palate, and one of those 5 is dedicated to the uvula. It's called the musculus uvulae, and it runs up and down the palate into the uvula. And so some people argue that it does have a role in the closure of the palate, whereas others say that it's a fastidial element from the fusion, and it doesn't have any functional role. So I think the majority of people I speak to tend to think that it doesn't have a great functional role, and we mainly reconstruct it from a cosmetic point of view in babies with a cleft palate, because it's one of the most common things that mothers and fathers ask. Are you going to reconstruct the dangly bit? Because I think that's what they want to see. And in some Asian populations, they put a lot of emphasis on how it looks, the uvula afterwards. So yes, I don't know the answer, but I think the consensus is it's mainly doesn't have an awful lot of functional role.